Well, I'm really pleased to be here, and I'm going to talk about implementation science, as Nick stated, and really its relevance and its application to newborn sequencing. I think we framed the topic by looking at the last century of healthcare innovations and healthcare scientific research breakthroughs, a lot of them in the fields of genetics, and really, step back for 1 second in a room like this and think about the following facts. We've discovered collectively that there are over 60,000 ways that the human body fails that we call disease. Over 7,000 of those, at least, are in the genetics realm, but that leaves another 52 or 53,000 in other realms. We've discovered mostly in the last 100 to 150 years, put a label, put a scientific method to. There are over 10,000 ways that we've discovered how to treat those failures, 4,000 of which are surgical or other therapeutic procedures, and 6,000 of which are drugs. So just incredible discovery, incredible rapid innovation, and it's probably what you're most interested in and why you're here. But, and this is the big but, and this is why I'm here, millions of people across the street and across the globe face needless suffering due to both breakdowns in the existing systems and lack of access to any systems of healthcare. And those failures cause millions of deaths and untold millions of people suffering needlessly. So we have, in many cases, the breakthroughs to save countless lives, to reduce untold suffering around the globe. And though we, as both a community, as a society, have a bias toward the breakthrough, I would argue that we need the follow-through innovations to ensure that these breakthroughs reach every person everywhere. And that's the world that I live in as a physician, as a public health practitioner, as having some space and work with the US government on payment policy, et cetera. How do we think about, with the same level of rigor, with the same level of intensity, with the same level of scientific and policy methodology, how do we think about building follow-through innovations to make sure that your innovations get to every person everywhere? The first step is to think about, and I'm just walking you through the journey of implementation science, is really to think about these breakdowns as perhaps being embodied by what we call no-do gaps, no with a K, not an N. No-do gaps really are the gaps that exist between what we know should happen for everyone everywhere and what does actually happen. And breaking those gaps down, why they happen, where they happen, to whom they happen, who is being counted, who is not being counted, and why. Those system failures range from the microprocesses to the mesosystems to the macrosystems and societal level forces. Naming, describing, and building and testing innovations that address those failures that cause suffering are a very important part of all of our work, whether we think of it as our work or not. And this is where implementation science and research comes in. Here's a definition from the NIH. There are many definitions, but what I'm going to walk you through really is what this science is, what it's still developing, and how it's used. It's really about integrating research finding and evidence into everyday policy and practice in the healthcare and public health environments. It's really understanding the behavior of different stakeholders, of different actors within the healthcare system, including but not limited to healthcare practitioners, and understanding how to increase, sometimes with a nudge, sometimes with a leap, the uptake of things that we know work in one environment and applying and understanding the context in which they may work or may not work in another environment. And then thinking with laser sharp focus about who's left behind, about fairness, about equity, about how we understand why things work in one place but don't in another. Implementation really looks at the processes and the outcomes around these evidence-based interventions. It really sort of says to the scientific community, it's wonderful if you brought a drug treatment to market. It's wonderful if you did an RCT to show its efficacy. But now, how does it advance outside of that one site, or those 3 sites, or that one pilot system that could do this? What contextual factors would inhibit or promote its advancement, and how do we move from efficacy to effectiveness? Sample questions that you might think about in the world of genetics, or can a genetic screening intervention be implemented in a place outside of where it's usually implemented? In my world, in primary care, adult primary care, pediatric primary care. Does this intervention improve uptake of screening? How, why, where, when? What this isn't is comparative effectiveness, efficacy, safety. It contains shades of those, but it's not those. It's really a how science of pragmatism. Pragmatism comes from the Greek pragma, to take action. That's implementation science. The why behind this is really because evidence-based interventions so often stay in the paper that they were published, or go into the library that they were produced, or in the one system. There's so often this gap in translation. We talk in the pharmaceutical space around the uptake of enormously effective medications that at minimum take a median of 17 years. How can you break down that 17-year gap? That's what implementation tries to do by applying systematic theory-based approaches. And that's one of the things I want to leave you with, is not a boring theory talk, but really to walk you through a little bit of the theory to suggest that this is not just a discipline of quality improvement or catch as catch can. There is a theory, a praxis, a method behind this. There's a literature behind this. And there's a valuable interchange between us in the implementation science, public health, and health policy application world, and you in the breakthrough genomics, genetics, rare disease, and non-rare disease space. The history really starts in the 60s with the understanding of this almost perverse or problematic, deleterious variability in healthcare practice across different locales. It starts then in the 70s, 80s, and 90s to the onset of what we would call eventually the evidence-based medicine revolution, or maybe it's not been a revolution, but the evidence-based medicine movement basically said, look, there are better and worse ways to do this. Let's be scientific about the practice of healthcare, and let's issue guidelines. And the problem with guidelines, as you know, is that they often live on shelves, whether they be bookshelves or electronic shelves, and that's not enough to say thou should do something. It has to move into action. And so in the 2000s, in the early publication of massive reports about our quality failures, and the input of behavioral economics and other quality improvement science, let people know that there was really a movement towards saying, well, maybe if we use nudges, or not so nudges, sledgehammers. If you don't do what the evidence says, we will take money away from you and pay for non-performance. Or if you do more good things, we will give you extra money. And here's 30 years of literature summarized on pay for performance in 2 sentences. Pay for performance induces time-limited, generally modest changes with often untoward consequences. You've seen it in the UK, we've seen it in North America, you may have seen it in other settings. I'm not saying that there shouldn't be pay for performance, but the idea of just nudging or hammering people with gains or losses is not enough to induce sustainable behavior change. The way to induce sustainable behavior change is have theory-based approaches grounded in evidence, which basically say, instead of if you don't do it, we'll hit you over the head, it's let's build a system together that makes it easier to do the right thing most of the time with equity. That's the way forward, and that takes a different approach. That takes frameworks that really describe that approach and allow us to work together across a variety of contexts. These are both context-specific approaches, meaning we deeply care about the context, but also context-agnostic in the sense that we don't really care about what condition you put in front of us. We can roll with you. We can work with you because there are some truisms that sort of apply across disease states or healthcare failures. So a couple of frameworks I just want to dip the toe in the water and then we can have a conversation about later, or if you're more interested, we'll talk over email. Some frameworks like EPIS, exploration, preparation, implementation, sustainment, are what we call determinant or formative frameworks. They really allow you to think about how do we take an evidence-based practice, that's what EBP means up there, and how do we evaluate how it's adopted into a clinical environment, how you prepare to launch a program in X or Y, what would that coaching and training need to be as it starts small and then scales? How do you begin to implement it? How do you think about critical things, leadership, financing of the intervention? This doesn't happen without those key variables. And then how do you understand if it was delivered with fidelity so that you can sustain it and assure it over time? So that's EPIS, a very good sort of turnkey or basic implementation science framework. In practice, so we are an implementation science outfit. We've used this to really apply and reapply a variety of tools. We do a lot of work, for instance, in surgical safety. We, with the WHO, built the surgical safety checklist that's in most ORs in high-income countries around the world, and about 30% of operating rooms in low-income countries. And really, we use this framework about exploration, preparation, implementation, sustainment. For instance, in this application of the safe surgery checklist in all of Singapore, but also an application to a new setting, which is a very dangerous moment in surgery, which is putting a new device into the operating room, one of the highest sources of morbidity and mortality. So again, this is just one example from a couple of months ago in the literature. Now, there's another kind of framework that we call more of an evaluative framework. This is a framework that you might think of evaluative or sort of summative in nature, called RE-AIM. It guides planning and dissemination, sort of more if you want to know, did my intervention work in an implementation lens? And do I have the chance, and what do I need to know to sort of scale it and spread it? This is about reach. It's about effectiveness. It's about adoption. It's about implementation and maintenance. And RE-AIM, interestingly, also really keys itself on multimodal forms of inquiry. It's not just about a quantitative RCT or quasi-experimental approach. It's also about qualitative approaches to understand that adaptation and maintenance over time. So how do we apply this in daily practice? We're about 12 years old. We were founded by the surgeon, Atul Gawande. We basically try to save lives and reduce suffering by melding human-centered design and prototyping to implementation science to scale the delivery and intervention of tools ranging from surgery to childbirth, to primary care, to end of life, to genomics. And so that really involves scaling innovation through real-world testing and implementation. The melding of a clinical discipline like genomics or genomic screening, and our partnership with Robert and Nick and the other members of the Genomes to People group, that sort of says, take a problem in that area and meld it with a set of scientists and designers in the innovation space, to design in the testing space, to implement, to know whether your prototype works, and in spread phase to implement and spread broadly. And how implementation science works in our context is really in the following way. In the design and prototyping phase, we use a lot of behavioral change models, like the health belief models, trans-theoretical models, to really input with our process and product designers how you take a good idea from the clinic. We want to do this part of newborn sequencing. We want to have this approach to consent. Okay, wonderful. So sit with a designer, use these behavioral change models to try to build a prototype to induce a change and start to test whether that change happens. Now, that testing often benefits from both determinant formative frameworks like EPIS that you can use to develop your early implementation strategies. It also benefits from quantitative study designs, again, quasi-experimental all the way to experimental RCT designs, to sort of say, great, we have just said in the space, you want to do an RCT, or you want to do a pragmatic RCT, or you want to do another different kind of study design, because it's not just take our word for it. You have to, if you have a good idea, if you have a prototype, you have to test it before you can tell the world to spread it. That differentiates implementation science from just standard QI, which is a sort of constant cycle of plan, do, study, act, that's sort of cycling and iterating toward hopeful improvement, but without that rigorous sort of sometimes linear test. And then in the spread phase, you want to use evaluative or often summative frameworks like RE-AIM to understand later spread, later application to different contexts, later understanding, oh, it worked, the RCT might have worked in context X, Y, and Z, but can it work in these other 4 countries? So by melding these sciences together and design processes, you can build interventions across spaces, as disparate as surgery to genomic sequencing. But we are here to genomic sequencing, so the question is, what's the no-do gap here, and what's the breakthrough to follow through work? And here, with so much credit, again, to Robert Green, to Nick Encina, to Aaron Drake, to the G2P folks and that we've been partnering with for the last 4 years, to Jason Vassie, our economo-genomicist, and other friends in the eMERGE network. This is team science. This isn't about like Ariadne Labs, sort of moving into spaces it knows nothing about. This is partnering. Sort of incredible advances as you're talking about a newborn genome sequencing and adult sequencing, using adult sequencing as a preventative tool, and then melding it to our sciences to sort of say, let's talk about the interplay to cross the chasm right there. So really, for us, the first set of work, again, this is all done together, has really been to say, how do we take the precision medicine for adults? And I know we're talking about newborns, but we started with adults to sort of take the leap from specialty care to primary care. What would it take to start to do that translation? How do we really, as been mentioned before, how do we train primary care practitioners to be ready for this, to want this, to see this actually not as an equity reducing tool, but an equity increasing tool? And here, really, this is borrowing from Roger's diffusion of innovation. You have to get out of the space of the tech enthusiasts or the early visionaries, and our program, Precision Population Health, starts to move into that pragmatist and even the conservative space as innovation diffuses. How do you make it easier to do the right thing in practice? Again, starting in adult health. So our first project, and I saw Hans here earlier, we worked with Corewell Health in Eastern Michigan to really design a process that builds on ACMG work around, at the time it was 73, now it's 84 genes, and a screening panel that, again, for me in primary care, internal medicine, the criteria is very clear. If if she wants to know whether she has the one or more of those genes, if present, would induce in me as her primary care practitioner a change in my recommended management, often in her screening or in her cardiovascular disease risk next Tuesday. That's our sort of category. And I think that that's where we're building up to in newborn sequencing. We're not perhaps there yet, but that's for adults what's been really wonderful to work on, the design and implementation and now pilot testing in Eastern Michigan of a set of tools to work at the point of care in primary care, to arm them and us, me, with just enough tools so that instead of saying we need 10,000 more genetic counselors and 2,000 more geneticists, how about use me and our teams, arm us with the information to be your extenders, to bring this science to fruition and reality in our clinics, and to do it in clinics that serve populations that traditionally and understandably have mistrust of genetics and genomics because of exclusion, systemic racism, and other history of untoward effects in the US and other healthcare systems, to use it as an equity promoting tool. And that's where we've been building with our partners at Corewell. This involved EPIS frameworks, preparation, interpretation of results, sharing plan, and critically co-creation of sets of tools and guides around clinical decision support, around conversation prompts for primary care clinicians to really make better conversations, to have better choices around what to do with these results. And lastly, and this is really exciting work, just started about 9 months ago with South Central Foundation, which is an amazing healthcare system in southern Alaska. It's a tribal health system as part of the Indian Health Service across the US. It's a sovereign tribe that is located in South Central Alaska that is one of the best health systems in the country. Enormous challenges that they face: poverty, morbidity, mortality, high rates of chronic disease, et cetera. And they've built some of the most amazing outcomes over the last 30 years. How? Really by co-designing quality improvement through what they call their customer owners, what we call patients. But I love what they call as customer owners because we are building a process in which South Central Foundation and the tribe in the area really wants to engage in adult population genomic screening and through primary care, but they want to do it their way and they want to own their data. We don't own their data, they own their data. So we're co-designing a set of ways to both train not just primary care clinicians, not just community health workers, but the customer owners in the system, the patients, to really take control, to build tools that match their environments, and to feel that they are the owners of their genomic information and their genomic trajectory. So I'm very excited about this work, and I guess that would leave me with closing thoughts to just say, don't mention patients last. Don't say that we need the patient voice last. Don't mention equity last. Mention it first. Bring people into co-design. It's not a nice to have to do co-design. If you want to get into implementation science, you quickly learn it's the smart play. It gets you there faster. Don't design something in your offices, in your scientific labs, and in your conference room and then bring it to the community. listen to the community first, co-design with them, and then you will get somewhere farther, faster, and with better outcomes. If we have a minute, do you want to take a couple questions?
Hello, I'm up at the back. Amanda from Genomics England, thank you so much for an excellent talk. I probably guess that most of us in this room are the early adopters and people bought into this idea. I'd love to hear more about what strategies you use and using co-design and implementation science to tackle those who are maybe understandably skeptic or very averse to the idea of change. How do you tackle those groups, whether that's patient groups, public groups, healthcare professionals?
Run toward criticism first. Find the skeptics and don't finger wag. Not that I know you wouldn't, Amanda. Don't finger wag or sort of say, such Luddites. They don't get it. Bring them in. Bring them in, not just in an insincere way, but ask them, help us understand, what is your concern? Often with clinicians, it's a workflow integration, and especially in primary care, I can't do one more thing. So make it easier for them to do one more thing. So ask them why they're worried, show them what's the value, understand their values despite your understanding of the value, and then work together with patients to implement it, as opposed to secret, and then thou shalt do it next Tuesday almost never works. But of course you wouldn't do that, but you would be surprised how often people think, well, it's in the literature, we have the evidence, just do it. Just do it is not a quality improvement strategy. Maybe it works for Nike, but not for this.